that this meeting, which we are doing along with Obesity Society, world famous Obesity Society of US, and today we have very eminent persons who will be speaking, who will be introduced by Dr. Purvi Chawla. Diabetes India, we are having more than 25 years in India. Dr. Shokar Sadikot, who founded this society before 25 years. This year, we are going to have our World Congress of Diabetes and Obesity in Hyderabad from 13th to 15th of Feb at a world-class convention center, which is Hyderabad International Convention Center. Our abstracts and registration both are open. Till today, we have already more than 300 registrations which are there, and more than 100 doctors going to get their travel grant if they apply at right time. This meeting is organized by Dr. Rakesh Rai and Dr. Manoj Chawla as the organizing secretary, which will be chaired by Dr. Vasant Kumar and Dr. Makkad as the organizing chair. Our president, Dr. S.R. Arvind, who will be giving his presidential oration during the meeting. We have more than 50 faculties who are going to come from all over the world. With these few words, I welcome you all to attend World Congress of Diabetes India. And now I introduce Dr. Purvi Chawla and Dr. Rakesh Rai, who will be chairing the session. Rakesh will join a little later. Dr. Purvi is a senior consultant, diabetologist, metabolic physician from city of Mumbai. She is director of Lina Diabetes Care Center and Metabolic Care Center at Mumbai. She is attached with many leading hospitals of Mumbai. She is also having many publications and a regular author for many textbooks of diabetes, obesity, and metabolic medicine. She is a regular feature on our social media, where RSSDI Facebook, live Facebook program, which we have done. She is our key speaker for doing a lot of awareness program, whether it is type 1, whether it's a obesity, or whether it's a diabetes. Today, we are very thankful to Dr. Purvi that she will be moderating this session of Diabetes India and Obesity Society. So now I request Dr. Purvi to introduce our speakers, and then we will have discussion at the end. We will be waiting for Dr. Rakesh Rai and Dr. Shashank also to join during the discussion. Over to Dr. Purvi.
Thank you so much, Dr. Banshi sir, for this fantastic opportunity. And once again, hello and welcome to this fabulous initiative and the culmination of the collaboration between two giants, Diabetes India and the Obesity Society based out of the US. Just for all of you who do not know much about the Obesity Society in the US, let me tell you that it's a scientific membership organization dedicated to improving people's lives by advancing the science-based understanding of the causes, consequences, prevention, and treatment of obesity. Also, their vision is to solve the challenges of obesity through deeper understanding and coordinated action. We could not agree more with that vision and the mission that they have. And I can assure you that it's very similar to what we are setting out to do as well. The Obesity School. Today's program is called Obesity School. And as the name alludes to school, let me remind you all that with the burgeoning epidemic of obesity looming on our heads and the urgent need to understand, train, and improve, and also practice obesity medicine, back to school is the trend and the mantra. And we really need to educate ourselves about everything, right from basics to bariatric or metabolic surgery, to do full justice not only to our patients and our practice, but also improve outcomes and lend a hand to prevention of obesity. We have three professional experts in our first webinar today, and I'm sure you will enjoy and benefit from their deliberations. As most learning happens through questions, I encourage you to send them in so that we can also share them with our speakers today and get the maximum out of them. RX Evans, may we share the series, please? Our first speaker for the evening is none other than, uh, yes, can you go to the next one, please? Our first speaker for the evening, who's going to speak about precision medicine and obesity management, is none other than Dr. Rucha Mehta, who's a physician and obesity medicine specialist, a consultant endocrinologist, and director of cardio-metabolic department at the Apollo and Edmo Clinic, Ahmedabad, and chair of research ethics committee at Muljibai Patil University Hospital, and the EC member of All India Association for Advancing Research in Obesity. She's also a professional member and expert on so many panels related to guidelines as well as on nutrition panels for developing guidelines as well as publications. So without much ado, let me welcome her and let her take over for the first talk.
Thank you so much, Purvi, for that kind introduction. It's great to be part of the Obesity School today, along with some really fantastic speakers. So let me just go ahead and share my screen so that we can get started. Let's see. Yeah, I hope, are you able to see my screen? Okay, so I feel the topic given to me was when I first started working on it, and then the sky was the limit. I thought we are still not in the era of precision medicine, and I was glad to see I was wrong and that there is so much happening, and there is so much more that we can learn from this. So, some of us who have been doing obesity management for more than a decade now, we also realize that what we are doing is not enough. In the next 15 minutes, that's what I'll try to talk to you about. As since I'm the first speaker, I thought it was mandatory to have some background slides that we know the global prevalence of obesity is increasing. We know more than 650 million people are living in the world with obesity, and India decided not to be left out. So we have close to 135 million people with obesity in India alone. And what's even more, impactful is that by the year 2040, more and more people will get affected, men and women, and sadly, children are going to be affected as well. So we need to really understand what we can do to nip this in the bud, so to speak. So why do we need to rethink obesity treatment? Because we know there is not a single country that is not being impacted by obesity. Obesity is so heterogeneous, not just in developing obesity, but also in the response to treatment. Hence, we know that one size fits all is not going to work any longer. BMI, which is being used as a criteria for management classification, has proven to be insufficient because there is a high relapse rate with all our genetic approaches, and hence there was a need for developing not just personalized care, but we move a step beyond that to precision care. So, what I will focus upon, even there's a lot to discuss over here, is the complexity of obesity and how we need to understand what is the phenotype approach and what is omics and how we can then tailor our approach for our clients. Now, as you all know, obesity is not simply calories in and calories out, though very often when we start managing our patients, that's what we boil it down to, but it has multiple pathophysiologic origins. Born with a genetic defect, whether it's monogenic or polygenic, then we have physiologic stimuli, and along with epigenetic influences, environmental influences, sociocultural and behavioral changes, all these factor in to lead to obesity. Hence, when we are managing a patient with obesity, it doesn't mean we can simply try to fix one of these things. We need to make sure the future is secure. And if that was not enough, you can see how environmental toxins, nutrient deficiencies, obesogenic or high fat diet can cause epigenetic perturbations of genes at several levels and not just at one levels. And we know that several genes may be playing a pathway in order to impact food intake as well as adiposity. Now, this energy balance again is complex. So, where do we start to begin? Do we work on energy intake? Do we work on the MC4 receptor? Where do we start working along the leptin pathway, the ghrelin pathway? So, what we do know, however, is that the response to diet is heterogeneous. The same diet given to 5 or 10 or 100 different people will result in a different weight loss. And what we also know that maintenance of this weight loss simply with lifestyle changes, as you can see over here, is challenging in most of these studies. A majority of the weight is regained once the diet intervention is stopped. Secondly, we know that we can give medications to prevent this weight regain. However, again, it doesn't work in everybody. So, how do we go about this? What do we do to better understand? And when we do all this, we have to still factor in that even though BMI is being used as a cutoff to measure obesity, is that the correct approach? We then moved on to the Edmonton obesity staging system, which tried to say that let's also factor in the complications. And though it was a complication driven pathway, we still failed to figure out what was wrong with an individual patient or a person living with obesity. And we just tried to focus on managing the patient if he had a medical, mental, or a functional complication. And let's not forget the thin fat Indian story. If it was so easy as measuring a BMI, a waist circumference, or a waist to hip ratio, and using the same cutoffs of 80 centimeters or 90 centimeters worldwide, we would all have been thin and not have to worry about it or all have been fat. And hence we need to individualize based on where the person comes from, what is going on with his lifestyle. As I mentioned to you, that most of the guidelines, whether you look at AHA, ACC, TOS, they always tell you to look at obesity guidelines based on BMI. For example, if the BMI is 25 to 29.9, you may simply use lifestyle interventions, diet, physical activity, behavioral therapy. You start adjunctive pharmacotherapy if there is an associated comorbidity. You consider surgery only if there is obesity class 3 or lower obesity with other complications. Now, is this the right approach? Are we doing justice to our patients? We know that BMI centric care has failed. We need to replace this BMI first thinking because there are several limitations. It poorly distinguishes whether we are losing fat versus muscle. It obscures the ectopic liver fat burden. It misses the sarcopenic obesity subtype. And hence, precision obesity care is something that's very important so that we can replace BMI first thinking with phenotype first thinking. And that is precisely what precision medicine is, tailoring the treatment based on the individual variability in biology, behavior, and environment so that your DNA doesn't have to be your destiny and we can figure out more innovative ways to go about doing this. Now, this was a very interesting figure. I thought that what we used to do in the past is what we learned in clinical medicine. We use clinical reasoning and the patient's history, and we can call that as intuition medicine. Then we moved on to the era of clinical guidelines that we are in right now, systematic reviews, clinical trials, and that's what we are doing right now presently. But the future is bright because what we are going to do in the future is going to personalize plans, look at the genome, look at epigenetic manifestations, understand phenotype and genotype, and come up with healthcare based unique traits, targeted therapies, and have individualized and precise treatments for our patients. And this is where obesity management, along with other disease management, is going to change. Let's look at such a trial conducted by Dr. Acosta and colleagues, wherein they decided we are in the era of anti obesity medications based on phenotype and whether that would lead to an enhanced weight loss versus the non phenotype approach. So, 450 subjects with obesity were evaluated for body composition, resting energy expenditure. They underwent questionnaires for satiety, satiation, eating behaviors, and physical activity was also measured by validated studies and questionnaire. Of course, we understand that obesity pathophysiology takes into account, as you can see over here, energy intake and energy expenditure. Based on the results of their questionnaires, they were able to divide majority of the subjects into those who were hungry all the time, and they were called hungry brain. Then there were people who ate because of emotional reasons, so they were called as the emotional hunger. The hungry gut, wherein they ate but the food passed out quickly, and in these patients they did gastric emptying studies. And then they also looked at metabolic rates and found some who did not metabolize fast. So they were called the slow metabolizers. And 12% were in that. 15% did not fit into any category and were called as unknown. Of course, there was overlap in some of the patients. Now, based on this, what they did is they looked at the eating behaviors, the homeostatic eating, the hedonic eating, and the energy expenditure. And this is a more detailed analysis of the questionnaires conducted. So what they found in the hungry brain patients were given phentermine topiramate extended release 7.5 milligrams daily or lorcaserin at 20 milligrams daily, which is an appetite suppressant. In the hungry gut, the ones who emptied fast were given liraglutide, Novo Nordisk 3 milligrams subcutaneous daily. In the emotional eaters were given oral naltrexone bupropion sustained release. And the slow burners were given phentermine 15 milligrams daily plus given increased resistance training. Let's see what happens. So, at the end of the year, it was noticed that in the phenotype patients versus the non phenotype patient, there was a 1.75 fold greater weight loss. Mean weight loss was almost 16% compared with 9% in the non phenotype guided group. And the proportion of patients who lost more than 10% weight was almost 80% in the phenotype guided group compared with only 34% in the non phenotype guided group. Albeit it's a small study, Dr. Acosta, who's a pioneer in precision medicine and has the Center of Precision Obesity Medicine at Mayo Clinic, has really set forward really great guidelines. This is just one of the studies I can show you. They have gone further to look at the genotype for these patients also and done further subtype studies and have proven that the proof of concept that response to a treatment can be engineered. This precision framework agrees that matching therapy to phenotype will outperform our conventional way of thinking. Now, let's move to the second part of my talk, which is the multi-omics approach. So, what omics simply means for some of you, I would like to just say it's that it's a scientific field that studies the complete set of biological molecules like genes, RNA, proteins, metabolites within a cell tissue and organism. For example, genomics refers to DNA. When we say transcriptomics, we refer to RNA. Proteomics will be the underlying protein, and metabolomics is the metabolites. So phenotype is the culmination of gene and then what happens epigenetically onto those. If we could understand phenotyping and genotyping, we could then work along the proteomic pathway, the microbiomic pathway, which is your gut microbiome, the metabolomic pathway, or even an RNA transcriptome, which I'll show you an example later on. And this would also help us to develop precision obesity medicine. And this is put together nicely as a graphic by them. And this is what I thought would stick in our minds. So, what is then precision obesity care for all of us as clinicians? The right treatment for the right patient and also at the right time. So, timing when you will do this treatment may also affect what we are doing later on. So, the multi-omics approach for precision obesity medicine would kind of be thought of as in a three stage is that at the early stage, as I mentioned, we could maybe prevent the onset of obesity, reducing risk factors for obesity. For example, if you know someone is born with a certain gene, modifying their behaviors right from the onset, knowing if they are a carb friendly gut prototype, giving them a low GI food. If you know that somebody is a fat friendly person, then you want to give them a fat friendly diet. Providing early and tailored lifestyle interventions. And in the intermediate and later stages, working with precision medicine, tailored lifestyle, offering surgery if that's indicated, pharmacology if that's indicated, and thereby reducing the risk factors for secondary diseases related to obesity. So I now present to you how I would look at this as the 5 domains of precision care. When we have a patient walking into the clinic, we need to understand their genetic background and their family history, hormonal and life stages. What is their metabolic phenotype? Can we predict their response to nutrition, exercise, or lifestyle changes? And lastly, what is the social context that they're living upon? Dr. Faruqi and colleagues have put together this very nice graphic showing you that it's not simply an energy intake and energy expenditure, but in the background of the genetics that you're born with, it's the environmental imprinting that then will cause a variation in body weight that we could now impact. So when we talk about metabolic phenotypes, and I'll quickly go through this, we are talking about the insulin resistant versus the insulin sensitive. Should we be using an insulin sensitizer right at the outset, along with a simple lifestyle change to make them succeed? Is there presence of metabolic syndrome? Lab guided decisions. Improving the gut microbiota is something that is being done now through targeted interventions. As I mentioned to you, we can use now, we have always known about exercise, using individualized nutrition, using prebiotics, probiotics, symbiotics, postbiotics, which may cause a general improvement in microbial composition for many. However, targeted therapies such as phage therapy and CRISPR therapy are now in the pipeline, which will allow us to specifically modify the metabolism related gut bacteria after doing a gut testing of the stool. And this is something that we should be considering in the future. What about the menopause, PCOS, looking at thyroid disease, sarcopenia, reversing aging, which has become, something that our patients ask us about all the time. Let's move now to a big topic, and I can only briefly talk about this, is precision nutrition and how digital technology is also enabling us to move in this era. So whenever we start talking about precision nutrition, tailoring the kind of protein, type of protein, and amount of protein for protein adequacy and carb personalization and meal timing. So we believe now we talk about uh, intermittent fasting and type of foods that are being used. And meal timing is something that is very big. So the digital twin technology using sensors, the Internet of Things, AI-based feedback has really allowed us to work with our clients to enable them. And it's a real-time feedback. So for example, if a patient will eat a wheat roti or a bowl of rice and he sees his sugar levels going up, it is certainly a better feedback than us telling them not to eat rice. If the sugar crosses 200, he's surely going to try to avoid that next time. Now, what's even beautiful is that not just a sugar feedback, we have also been able to, with the twin technologies, they collect several data points with sensor data, medication data, behavior when you're moving. And not only does it allow us to change their nutrition, but improves compliance with medications, improves sleep quality, precision activity, breathing, recovery. So all of this has been possible with several of these digital models available to us. I only quote one of them today. Similarly, we have even been able to figure out what level of exercise is better, resistance training versus cardio versus a combination of the two for our clients. I just showed you how Dr. Acosta and colleagues use phenotype guided pharmacotherapy, and that, my friends, in your patients who fail GLP-1 therapies, may be the future as to when do you select what for somebody. Again, when is surgery indicated? This is going to be something that is going to be much easier for us to figure out in the future at the very outset. Now, what I thought was very interesting was this study about social network and the spread of obesity in a large social network over 32 years. These are 12,000 people who were assessed as a subset of the Framingham Heart Study. And what it was found is how your social network is one of the biggest enablers. So if you have a friend, a mutual friend who's gaining weight, if you have a spouse who's gaining weight, a sibling who's gaining weight, you are more likely to gain weight. There's an increased risk of obesity. However, what was interesting, if you have an opposite sex friend, you're probably likely to lose weight. So maybe if all of us need to get out and have a friend of the opposite sex. And that was something if I learned. And they go on to say how the social network is going to impact our metabolic network, and that will cause the spread of disease in our society as a whole. So I think this is a huge thing to work upon. And this is where I will just stop and kind of say these are the 5 domains of precision care, how we can work upon them. And it is now time to move beyond this scale. Our clients want to know the future, and we can really give them good answers that hopefully we will be able to impact not just weight, but metabolic health, quality of life, and in a very sustainable fashion. So I think I'll stop right here and hand it back to Purvi. Thank you very much.
Thank you for that fantastic talk. And really, I think I was thinking at several time points in during your talk that, yes, how could we, apply this to our Indian setting? And I think really very well alluded to that. So thank you, but we will take all the formal questions later. I think we can move on to the second talk. And we have none other than Dr. Sabyasachi Sen. Um, he is a senior endocrinologist lipidologist and obesity medicine specialist, the chief of endocrinology, diabetes and metabolism at Veterans Affairs Medical Center, Washington, D.C. He's also the professor at the Department of Medicine, Endocrinology, and professor of biochemistry and molecular medicine at the George Washington University in the US. Clinical professor, Uniform Services University of the Sciences at Bethesda. And his basic research interest has involved behavior, survival, and differentiation of human adult stem cells in hyperglycemia. And current research projects include those on the effect of exercise, incretins, and glucose transport inhibitors and artificial sweeteners on endothelial function and endothelial progenitor cells in patients with prediabetes as well as diabetes. I can go on and on. It's a thesis by itself, his introduction, but let me not take away this time that he has with you all. So without much ado, Dr. Sabyasachi Sen, he will be deliberating on obesity and MASLD or metabolic dysfunction associated steatotic liver disease. And I also welcome Dr. Rakesh Sahai sir, who has joined us. He is the moderator for today. And so welcome.
Good
He
evening.
is senior endocrinologist, and he, like Dr. Banshi Sabu sir said, he is organizing Diabetes India, the annual conference 2026. And so we are really glad you could join in, and you're here today.
Thank you. Good
So
evening. Yeah, look forward to Dr. Sabyasachi's talk. Yeah.
Thank you. Can you guys hear me?
yes,
Yeah.
sir.
Awesome. Thanks, Purvi, for the kind introduction, Dr. Chawla. It's actually interesting that on the slide, I saw that I'm still associate professor of medicine and anatomy. That was 6 years back. I've
I'm
been professor
talking
for
you,
last-
Dr. Sen.
So it just shows how long I've been involved with Diabetes India and all of you guys. So thank you so much for the invitation. Let me try to share my slide. This is always interesting.
Yes.
Yeah. We can see.
Is it full screen?
Yes.
Yeah, now it's on.
Awesome.
It's in the presentation mode that you are seeing on the laptop. Could you put it on full screen?
How do I do that?
Yeah, so that may be the one. Yeah.
Is that it? It's not full screen yet?
Not yet.
Oh,
I think you can
display
switch,
settings, is it?
get out of it and come back again to full screen.
Oh.
I think here itself, if you go to that bottom icon.
This one?
Oh,
Which
the
one?
previous
Let me try to see.
maybe that works.
Did that work?
No. Yeah.
No.
Now it's working.
Now
Yes.
it's fine. Now it's fine.
Perfect.
Perfect.
Awesome. Great. So thank you for giving me this topic, because we in Washington, D.C., in conjunction with Georgetown, George Washington, and Hopkins, is actively trying to address MASLD from endocrinology point of view. So I'm going to address some of the issues that's facing us in the United States, and I'm sure it's the same in India as well. So the link between obesity and MASLD, I think um, Rucha has actually gave a very thorough overview and into the genetics as well, that obesity and metabolic syndrome are fairly tightly linked with excess body fat, causing a buildup of adipogenicity. Next comes the inflammation in the liver, secondary to the so-called energy storage or increase of adipocytes in the liver, leading to hepatosteatosis or inflammation of the Hepar cells, fibrosis, and cirrhosis. The magnitude of the disease is quite large in the sense that over 70 to 90% of people with MASLD have obesity, and obesity being the prime driver. So there is clearly a very close interlink between the two diseases. So as I said, mechanisms include excess fat accumulation, number one. Number two being insulin resistance, a core issue where the body doesn't use enough insulin properly. Number three being inflammation, and associated cause would be metabolic syndrome. The reason I'm talking about metabolic syndrome is that is one of the criteria we use to diagnose MASLD. So here is the pictographical explanation of what I just said. So outline of my talk today would be the stages of liver damage, talk very briefly on the MASLD nomenclature, criteria of MASLD. I would focus on the so-called clinical features, diagnosis and management more than any of the other paradigms that you see here. So MASLD progression. So first, doesn't involve inflammation or hepatosteatosis. As you know, itis would mean inflammation. So pre-inflammation would be essentially MASL, which subsequently progresses to MASH, right? So the inflammation situation in MASL is fairly mild. Subsequently, it progresses fairly fast. From about 41% of the patients would progress to fibrosis, F0, F1, F2, and F3. And I'm going to talk about our diagnostic procedures such as fibroscan and so on, which actually tries to distinguish between different stages and therefore the medications that are approved at those stages. So as you can see, 41% of the patient of MASH will progress further, and another 25% would progress to a advanced fibrosis or cirrhosis stage. So MASLD is a multi-system disease, and usually in addition to hepatosteatosis, 1 out of 5 cardiometabolic factors are usually present. The patients with hepatosteatosis and the alcohol use is also shown here. The alcohol use is actually on the low side, with less than 50 grams per day in females and less than 60 grams per day in males. And this helps us to distinguish between an alcoholic hepatitis versus non-alcoholic hepatitis. And this is kind of important because a lot of our patients could be taking a significant amount of alcohol as well. Now, the histology of MASLD is important. What is the main criteria of histology for MASLD? Number one being the so-called multiple ballooned hepatocytes. So when we do biopsy, and I do biopsy on some of our patients on liver, and we actually do see this ballooning, and that has multiple stages up to stage C or 3 here. And then you can actually see hepatitis when there's macrophage infiltration in these inflammatory hepatocytes, subsequently leading to fibrosis, which you can see here. I don't know whether the pointer is actually showing. And then if you stain it subsequently, this is a eosinophil, H&E staining, where you can actually see the fibrosis here and the inflammation subsequently at the pink eosinophil or eosin positive cells, and subsequently cirrhosis being at the stage F on the very right hand corner. So this is the criteria that we at that AASLD would ask you to follow. There's an adult criteria and pediatric criteria. I'm sure all of you would know, but if you take a quick glance, you would see that the criteria is very similar to metabolic syndrome criteria, not 100%, but there is a large amount of similarity for the criteria of MASL with metabolic syndrome, and that's why those parameters are important. It's also important to note that some of the lipid parameters such as LDL does not feature here. It's primarily triglyceride, and I'm going to talk a little bit more about it in the management plan. So the MASL being is the most commonest cause of chronic liver disease in the United States and worldwide, and I would say also in India. MASL risk is about 4 to 10 times higher in patients with metabolic syndrome. We already talked about that. And also, the MASL is further classified as non-alcoholic with isolated steatosis and NASH by liver cell injury and so on. And prime mechanism being the infiltration or accumulation of inflammatory cells. So around 20 to 25% of MASL patients would develop MASH or NASH, okay? So you need to be very clear about it when you are counseling your patients. And then subsequently, around 6% of your MASH and NASH patients would subsequently develop cirrhosis, and 1 to 2% would subsequently progress to full-fledged hepatocellular carcinoma. In fact, one of our patients in Baltimore was recently diagnosed with hepatocellular carcinoma. So clinical features, as you all know, most of our patients could be asymptomatic, particularly at the MASL stage, and so-called Palmer erythema and angiomata are seen in some patients, but that's usually at a later on phase. Okay, and we diagnose based on AST and ALT elevations are almost 2 to 5 times the upper limit of normal. AST and ALT ratio is less than 1, unlike that of alcohol. This often comes up in our endocrine boards. And serum ferritin can also be elevated because it's an acute phase reactant and mimics the inflammatory pathways. Prothrombin time is usually normal except in patients with cirrhosis, but remember, some of these patients also have thrombocytopenia. And I'm going to talk a bit more about the scoring that some of us use called FIB-4, where the platelet sits at the denominator. So if the platelet is low, your FIB-4 score will be high, indicating a higher chance of fibrosis in a MASL or MASH patient. So keep an eye on the platelet values as well while you are following AST and ALT. In isolated fatty liver, they may not be enlarged in transaminitis and so on, but we need to follow those patients over a period of time. Risk factors for MASL, as you all know, weight, diabetes, glycemia, lipid profile, and thyroid function tests, and so on. We kind of covered all these points, except that the autoimmune hepatitis needs to be also kept in mind, and one needs to exclude Wilson's and hemochromatosis as a possible liver damage entities as autoimmune diseases. So imaging studies, one can do so-called ultrasound, which actually would show the fat, but doesn't differentiate between MASL and MASH. In other words, cannot pick up extent of fibrosis. CT and MRI can, but it adds to the expense. And here comes the main modality that we use for diagnosis and management would be fibroscan or transient elastography. It's done to detect primarily the fibrosis. It's a measurement of pressure inside the liver. Okay, so and the MRI is still the gold standard. It has much higher sensitivity, but it's actually a little bit better than the fibroscan. But as I mentioned before in the last slide, that it's quite expensive. So our main modality of diagnosis is fibroscan. How do you do it? This is essentially the machine. I don't know how many of you are actually doing it in our clinic. We do it regularly. I have a clinic on Monday and Wednesday where we actually routinely do these tests. How do you know that you're actually at the right place? You need to be at an intercostal space. Your line should be fairly clear as it's shown on the examination C. And then you can also look at if this, for example, if you look at the lower panel and if your images are very much to the right, where there is not a clear delineation of the canaliculi, then you are not getting the real pressure evaluation. One thing is CAP score. There's two things that the FibroScan machine gives you. One is a CAP score, and the other one is called a KPA or a pressure or kilopascals, which is essentially a pressure management. If you look at your car tire pressure, it's actually also measured in KPA. So essentially, this is a pressure measure inside the liver. So as you can see at the lowest line here, your F2 is about 7.5 to 10. Some literature would coin it as 8 to 12. If it is more than 10 or 12, it's considered severe or F3. So essentially, if you have 8 to 12, which is our prime guide, that's when we say that the patient has moderate scarring. What does that mean? That means that that patient needs treatment and diet and exercise and so on is not enough. So if you want to establish that for fibrosis, you can go ahead and do a biopsy rather than doing an MRI and so on, and biopsy is still a gold standard for diagnosis. Most of the studies have actually used biopsy in conjunction with elastography. Now, diet and exercise is helpful in stage F0 and F1. You need to lose about 7 to 10%, not 3 to 5% really, 7 to 10% over a 6-month period to show any difference in inflammation. Different diets have been looked at. I'm not going to spend too much time on this, but the most important thing is to counsel your patients to avoid alcohol intake. Exercise, you need to do at least moderate to high dose of exercise. If that doesn't help, obesity needs to be treated with certain drugs that are approved at your space. In the United States, it's phentermine, orlistat, topiramate, or its combinations, and GLP-1 per se. Okay, so the management, I don't want to, this is a slide from Endocrine Society. I don't want you to look at everything here. What I want you to look at is the very lower portion where you have a pharmacotherapy for obesity and type 2 diabetes, along with fibrosis risk. So low, intermediate, and high, as you can see, if you are intermediate or high, intermediate being F2 to F3, you need to consider agents such as GLP-1 or resveratrol and so on. In low stages, when you have diabetes, you can consider glitazones and GLP-1 or SGLT2. In our hands, SGLT2 has not panned out very successful compared to GLP-1. So pharmacotherapy, where does resveratrol, the two main drugs that are approved in the United States and hopefully in India as well, is resveratrol and semaglutide, right? And the main difference of resveratrol, main mechanism of resveratrol is that it's a thyroid hormone receptor beta 2 agonist, which increases fat breakdown, lowers liver fat, and improves liver profile, including LDL and triglycerides. If any of you follow this form of literature on lipids and liver disease, you would remember there was a similar drug like resveratrol called epriterome, which was published in 2010 in New England Journal of Medicine, which was also a thyroid beta 2 receptor agonist and showed incredible lipid lowering results. So GLP-1, on the other hand, the mechanism is primarily based on glucose lowering and weight reduction, not so much to do with lipid results independent of weight reduction. So the key differences, I've recently gave a talk at ADA, and this was the main summary in the sense that the key differences of these two drugs is GLP-1 would help you to lose weight. Resveratrol does not have much impact on the weight, so it's more of a weight neutral drug. Resveratrol, however, has a direct effect on liver fat reduction, which subsequently helps to reduce intra-liver inflammation. Resveratrol significantly would lower the LDL and triglyceride, as I mentioned. GLP effect is primarily based on weight reduction and degree of weight loss. So the application is resveratrol is more liver focused. If somebody has significant fibrosis, that drug should be there as an individual on its own or in combination with GLP-1. We, in our elderly patients, tend to use combination of a low dose GLP-1 and resveratrol, and the results are quite interesting, and we are following that cohort as well. Dyslipidemia management is important in this population and in these patients. You need to consider lowering not just the cholesterol moieties and atherogenic moieties such as LDL, HDL, and IDL, but also you need to reduce the so-called intestinal lipids such as triglyceride by using a combination of statin and fibrates. Without controlling triglycerides and increasing HDL, this disease is very difficult to be controlled. You have a role of bariatric surgery, of course, by reducing weight, and I'm not going to deliver too much on that. And also at the last stage would be liver transplantation, and it is now has become the third most common cause of liver transplantation, unfortunately, after cirrhosis caused by hepatitis C virus and alcoholic liver disease. So unfortunately, however, MASL can recur after transplantation, and you need to counsel your patients accordingly, though the percentage may be low, but one needs to be aware of that fact. Thank you. I think that was my last slide. If you have any questions, I'm happy to take them. Hopefully this was more practical management of MASL rather than things that we don't do usually. Thank you.
Thank you so much, Dr. Sen. That was a fabulous talk. And I think you're a true professor, really well explained.
Thank you.
Dr. Rakesh, sir, if
Yeah, thank you. Thank you, Dr. Sen. Excellent talk. Gave a very crystal clear view of MSLD and its management. We look forward to any questions from the audience. And
Sure. Thank you.
So we can have a quick discussion at the end of the last talk.
okay, so we'll move on to the next presentation and then have a discussion at the end of the last talk.
So Shashank video is there. You ask the RX team to start it. He
Sir,
also
Dr.
joined, so he will
Shashank
do
sir
it.
has joined. Yeah.
I know, but his record The talk is there, then he will join for the discussion. Okay.
Today we are going to discuss future of obesity therapy. And future of obesity therapy is totally transformed. In fact, I don't have any duality and conflict of interest for this talk. But one fact before I talk on future of obesity is a disease. And we have to get into a chronic care model. And one of the most evidence-based pathways and frameworks for obesity is the ACE algorithm, which has just been unveiled a couple of weeks back. And fundamentally, we need to address the stigma and bias when we are managing people living with obesity. So we need to have an activated, empowered patient, society, prepared healthcare system to get the optimal outcome. So we need to beat the weight stigma and overcome the psychological effects. So fundamentally, there is a psychological model for adiposity-based chronic disease or obesity. And very clearly, we need to recognize the biological underpinnings, the social factors, and psychological factors. We also recognize that there's a triple burden now. Obesity, type 2 diabetes, and cardiovascular burden is connected. And therefore, I like to use the word, not to use the word obesity, but what Jeffrey Mechanic said, adiposity-based chronic disease, which is adiposity, which is based on the adipose tissue mass, function, and distribution. It's a chronic disease which reflects the presence of risk, presence of severity of complications. DBCD, which is dysglycemia-based chronic disease, which is nothing but type 2 diabetes, prediabetes, and insulin resistance associated with disease progression. But we need a medically actionable model. And that medically actionable model is provided by the term CMBCD, which is cardiometabolic-based chronic disease. And therefore, then there is a compelling need to treat these individuals with therapies, treatments, medical treatments, surgical treatments, and the intertwining of relationship between obesity, type 2 diabetes, and heart disease. So fundamentally, hit hard, hit early. We need to do primary, secondary, tertiary, and quaternary prevention to prevent end-stage development of chronic disease processes. So stage 1 of any disease, whether it's ABCD, DBCD, or CMBCD, is at risk. Stage 2 is pre-disease. Stage 3 is disease, and stage 4 is complications. And we need to reverse these trends. And therefore, if you really want to have a population-based strategy, we need an early sustained intervention directed towards control of metabolic drivers, including functional adiposity, dysglycemia, and hypertension. So fundamentally, we need to address ABCD, DBCD, and CMPCD, and we need to attack it at risk stage. Earlier, the better. And therefore, when we look at metabolic modulators and connecting the loop, we need to look at the mechanical and the metabolic possibilities of addressing the issue of people living with that ectopic fat. And we need to ensure the glucotoxicity, the lipotoxicity, the oxidative health, and reverse the disease modification through various organs, whether it is the beta or alpha cells, or the cardiomyocytes, or the ectopic epicardial fat, or the adipose tissue, or the myocellular fat, or the endothelium, or the liver fat. And we need to ensure that we need to get the substrates right so that we can reverse dyslipidemia, type 2 diabetes, blood pressure, and cardiovascular risk. We also need to recognize one more term before I address future of obesity, is the kg-A1C paradox. Because if we reduce weight, we clearly recognize that the A1C comes down. So the 5 A's of obesity are very clear. Ask if you can discuss about weight and impact of obesity, assess the health status and complications, advise on treatment options based on severity of obesity, agree to a treatment plan and weight loss goals, and assist the continuous process of weight management. So originally it was lifestyle, meal replacement, behavioral therapy, AI-enabled web-based systems, patient support systems, diet and exercise. That was the core center of obesity therapy. But the modern future is all about pharmacotherapy. And this whole generation which is going to be born is not a Gen Z. It's not the millennials. It is a GLP-1 generation. So we have moved and migrated from the orlistats of the world and 3 milligram liraglutides of the world and the semaglutides of the world, which is getting off patents. We have moved away from naltrexone, bupropion, phentermine, topiramate to a tirzepatide, to a retatrutide, and to agrisimas of the world. And they are going to be the future of obesity. We are also seeing surgical advances like endobariatrics, a whole new science of endoscopic sleeves, endoscopic bands, and the Roux-en-Y will be an endoscopic procedure now. So the endobariatrics and the dual triple agents are going to be future of obesity. That's where obesity science is going to evolve. But remember, for an anti-obesity drug, the core is 5% weight loss. And we are now getting right up to 50, 35, 40% weight loss with bariatric surgery and some compelling agents. So clearly, weight loss is important, but weight maintenance is equally important because of the rebound phenomenon. So very clearly we know that lifestyle often fails and the rebound is quite palpable. But pharmacotherapy can maintain that. And we also know that we have to contextualize now diabetes treatment in the context of weight. So we had weight neutral drugs, we had weight gain drugs, but now we are looking at weight loss drugs when we contextualize the entire management of diabetes space. And therefore, the entire diabetes space is addressed from a downstream approach. And we clearly recognize that we have to move the gear from a downstream approach, which was a traditional approach, complication centric, glucocentric approach, to a weight centric upstream approach, which is hitting the root cause of adiposopathy. And therefore, a weight centric upstream approach will not only disrupt the underlying pathophysiology of type 2 diabetes, but slow and reverse the disease. So the future of obesity therapy is about disease modification and about cardiovascular risk factor prevention, macro and macrovascular complications. And if you get 15% weight loss, we can get remission. And with 10 to 15%, we can get comorbidity and mortality and mechanical prevention. At 5 to 10%, we'll get prevention of type 2 diabetes, PCOS resolution, MAFLD resolution, dyslipidemia resolution. So clearly we can see 5 to 15% weight loss is a reality. It is a disease modifying effect, improves quality of life, metabolic improvement in cardiometabolic risk. And therefore, if you see the 2025-26 algorithm of AD approach, very clearly you can see high efficacy weight loss agents of tirzepatide, semaglutide right up there in the pecking order, which are now available even in the Indian subcontinent. And very clearly we can see that the decision to use GLP-1 receptor agents are clearly outweighing even the benefits of that of SGLT2 inhibitors. And clearly choosing a glucose lowering therapy with a high to very high dual weight and glucose lowering options is a standard of care. And then we can move the handle from a cardiometabolic based chronic condition and move it from complications to disease to pre-disease to at risk. So we can actually look at a reversal process with these disease modifying agents. I don't like the word obesity. I like ABCD or adiposopathy because BMI is a very poor matrix. Fat quantity matters, fat quality matters, the location matters. Adiposopathy is a pathogenic driver of a disease continuum, and we need to address goals and outcomes with disease states. Unfortunately, anti-obesity management was fraught with missteps like thyroxine, the DNPs, the amphetamines, the aminorex, they all had hypertension clauses. Fenfluramine, the fenfluramine, the leptins had their own problems. The rimonabants, the sibutramines, the locarcimins all got banned. So unfortunately, every anti-obesity medicine which came on planet Earth got banned. And therefore, pharmacovigilance is the key. Even if you are in the future of obesity therapy, pharmacovigilance is my first take-home message to everybody. That be vigilant for side effects because these are new agents. But we can address appetite better. We can address eating for hunger, homeostatic eating. We can address eating for pleasure, hedonic eating, and we can just eating, which is executive function. And we can address this triad of appetite with switching off with the modern agents of GLP-1 axis. So clearly, nobody thought that the incretin axis will give us so much. And so many peptides, which can be modulated in the entire obesity spectrum for future obesity. And we clearly recognize the role of the K and the L cells of GIP and GLP-1 axis. And we can actually combine various agents of glucagon, GIP, and GLP-1 to get pharmacological analogs. And the pharmacological analogs of GLP-1, pharmacological duopoly and quadripoly of a GIP, GLP, glucagon axis of activation or inhibition has created the entire spectrum of the entire obesity future. And we can see this complex architecture here is browning of fat, switching off the appetite, improvement of FGF21, ensuring that we switch off the appetite, we just look at food and have satiety and expend energy and eat less. So GLP was simple. Switching on beta cells, switching off alpha cells, insulin and glucagon. But they also delayed gastric emptying and GI motility and switched off water and food intake. Then, of course, we know that GLP was an appetite modulator, and clearly we recognize it. Whether it's the gut and the brain, the GLP-1 peptide had its impact. But people moved beyond GLP-1 into the GLP-1 receptor biology, in the satiety centers, in the liver fat, the muscle fat, and in the GI motility. And therefore, we recognize these effects much better. Of course, liraglutide was the first kid off the block, with 3 milligram being approved for obesity as a standard of care, but it was a daily agent. Then came, of course, semaglutide. Different molecule because it had a homeostatic and hedonic impact on appetite regulation. There were different formulations of semaglutide. We have the oral 3, 7, 14, and now 25, 50 coming up. That's the future. We have 0.5, 0.25, and 1 milligram of semaglutide, which will become generic. Then we have 2.4 semaglutide, and we'll also get double dose of that. And in fact, oral semaglutide also is now approved by, and the injectable Wegovy is also approved by the US FDA. You must have read it in the newspapers. So that is from the semaglutide stable. And they're anti-atherosclerotic. The GLP-1 receptors not only reduce the inflammation, but lipid deposition and anti-atherosclerosis. Then came the second generation. And the second generation are the ones which had GIP. So we had the dual and triple antagonists, where you have GLP-1 GIP analog, we have GLP-1 receptor and glucagon receptor agonist, we have GLP-1 GIP with glucagon receptor agonist, the triple agent. And we had amylin agonist, which is cagrilintide and cagrilintide, which is amylin with GLP-1. All of them are here to stay. So clearly, when we are looking at impacting, these agents are having weight loss between 10, 15, 20%, which are equal to that of bariatric surgery. And the diabetes is definitely a rate limiting step, presence of diabetes on the weight loss part of it. But otherwise, you can see that they are competing with the traditional bariatric surgeons. And these are the discoverers of this entire GLP-1 GIP axis, DeMarchi, and the person who gave the Banting lecture a couple of years back. Clearly, we can recognize and see them that these two gentlemen were revolutionary. They were on a joint mission project, and they were having this multi-receptor agents, and tirzepatide is standard of care. And clearly, you can see if you combine and reposition the peptide family of glucagon, of GLP-1 and GIP, we are creating a super hormone combining action profiles. And this action profile is really the future. And such an action profile is available now. We just saw data just published 2-3 weeks back of the triple agent of GIP, GLP-1 and glucagon, the triple G, 25-30% weight loss with disease remission. Unique results, very, and therefore this controlling obesity with multi-receptor drugs is a standard of care. And they will revolutionize care worldwide. So obviously we need a reality check. Obesity is no more a guilt complex. It is no more an individual choice and lack of willpower, because obesity is a disease. Appetite is complexly regulated in the gut and the brain, and we can attack it. And therefore, people living with obesity must be aware that it's a complex disease. It's not with lifestyle. There is no need to have a harmful self-blame. We can attack it. We can stage it. Arya Sharma from Canada, who now lives in Berlin, stage it with the Edmonton obesity staging system. And we can actually stage the obesity into various risk factor triages. We can have lifestyle for people without risk. We can have behavioral therapy with risk factors. We can have medical management for people with complications. And if there's morbid obese cases, there may still be a limited role for bariatric surgery. And therefore, this whole algorithm in 2025 update has been put out as an ABCD update by the American College of Clinical Endocrinology. And they have made a beautiful draft. And I would recognize that in the ABCD conglomerate, there is preclinical stage 1 ACE obesity. Then there's clinical obesity with obesity-related diseases. So you have to stage it as stage 1, stage 2, and stage 3 when we are looking at the entire complication-centric rate. It's very evidence-based with excellent visuals. We need to recognize that ABCD is a complex clinical condition. We need to go beyond BMI. We need to leverage the future obesity therapy with second-generation agents with 15% of weight loss. We need to personalize and intensify lifestyle. We need to shift the focus away from just an isolated endpoint into entire comprehensive weight loss targets as tools, and we need to address the bias. And clearly, we see that the entire algorithm is beautiful. You can go through it, and we can go into a complication-centric model, but you need to be aggressive. We need to do oxology and clinical components of care. We need to measure it appropriately and then aggressively address it. And across all stages of obesity, we need to recognize two things: obesity complications and obesity related diseases, because they can be reversed. Assess the patient correctly, stage the ABCD algorithm, develop a shared decision making plan, and follow up. And you can eliminate diseases. Up to 35-40% of weight loss and fat loss is doable, possible with the modern agents. And that is something which is standard of care. And clearly, we can see these weight loss targets are achievable. We can do them with integrating behavioral and lifestyle modifications, physical activity, and a patient-centric complication model. And we can see that each one of these models can have compelling indications. These are all the current FDA-approved medications. In India, we clearly have the 3 milligram liraglutide not yet available, but the lower version of liraglutide is available. Semaglutide available in all forms, and I might get generic, and tirzepatide available. Though they are available, and other agents are in the on-will in times to come, and they can be used efficiently for weight loss. So clearly, we recognize that obesity, though is a chronic disease, we are in the best of times. But as Charles Dickens said, we are also in the worst of times. Pharmacovigilance is the key. Algorithmic approach is the key. Go through the algorithm of ACE, which is a live document. But whenever you are looking at weight loss, emphasize on dietary protein, preserve muscle mass and function, look at mental health and bone health, be onco-vigilant, and focus on health outcomes. And beyond that, try to ensure that you integrate health and happiness outcomes together. Prevention mantra is still the core, but future of obesity is bright with novel agents, and that's something which I recognize. Thank you so much for a patient hearing.
Thank you, Dr. Shashank. You put the obesity management in the right perspective.
I agree, sir. That was absolutely fabulous. Do we have all the speakers? We could do some quick
Yeah.
questions. We do have some time for that.
So thank you so much, Rakesh, Purvi, Bansi, for having me over. It's a pleasure. Sorry, I had to record it because I had another talk. So I thought both will clash, but fortunately this was okay. Hi, Sabi, how are you?
Hi.
How
So
cold is
we-
it?
One second.
Rucha is there?
Acha.
Yes, she was. So we can start with some questions. The giants are here, and let's pick their brains and get some some more meat out of that. Uh, so Dr. Joshi, sir, what do you think, when we talk about algorithms, we talk about all the management options that we have. Today, we literally are in an era where patients are choosing the therapy and coming to us. But, at the primary care level, what do you think is the most important? And, like recently, I have two questions. One is the primary care physician, what is your message to them with respect to obesity practice? And secondly, I want to share recently at an obesity workshop. I was very surprised and actually a tad bit disappointed too, because somebody said that, yeah, in the 5 minutes that we get with the patient, you want us to ask for permission, and, uh, if it's good for the patient, you've got to do it. While I agree with that, line of management, I do not agree with breaking the autonomy of the patient with respect to obesity management. I would really love your views on that.
I think, Purvi, those are great questions. I think, first of all, we have to be very respectful of people living with obesity and people living with diabetes. And I think the first point is to do a shared decision making with them. So there is no bypassing, there is no shortcut. I think the first thing is that these are evidence-based drugs. These are pharmaceutical prescription drugs to be given by physicians or endocrinologists. And they must go through the filter of contraindications. They must go through the filter of do's and don'ts. They must have the pre-mandatory checks, which are done under supervision of a qualified medical personnel. And therefore, it is time that primary care or tertiary care take the clutches of obesity management in their hands. Because as I said, as Charles Dickens said, we are in best of time, but worst of time. We are in best of times because we have so many tools available, and tools are getting better and better every day. We are in worst of times is because, people actually are walking up to clinics and saying, Doc, I want to use this drug. But their need, the person's need is more cosmetic. The person's need is more in a FOMO that my entire club is taking it, my entire friend circle is taking it, my entire WhatsApp group is taking it. So they are in that FOMO mode. So we have to filter. We have to see that there is no thyroid nodule, there is no pancreatic gallstones, there are no risk factors for pancreatitis which are red flagging with more than 2 or 3 risk factors. And once we are convinced that there is no red flag, we educate them on the adverse events. We start low, go low, slow. We tell them very clearly there's no role for microdosing. We do clear muscle evaluation on them, emphasize the point of muscle strengthening exercises, appropriate their protein intake, give them adequate water on board, ensure that their bone health is preserved. So I think if we are able to do a conversation, Purvi, I think it's worth it. And I think even if it takes that extra 5 or 10 minutes, it's clearly worth it. I am doing two things. One is, lot of that can be pre-recorded in a video. And as the patient is waiting in the waiting room, they can actually go through some of these FAQs. And I would urge each one of you to do a little FAQ video of your own. It is very useful for the doctors at large. Because if you do that, patients, they are waiting for you. They have already, lot of their questions in their mind are already answered. And you are talking it. So it's like they're going over it. Okay. And the second thing which I do is how to take the injection or the tablet. Actually, if you do again that as a demo video with you or your team, again, it's very useful because a lot of FAQs surrounding that. How many clicks, how to rotate, what to do, what happens if it goes up and down, what happens if I skip the dose, if I now it's like the season, can I take 2 doses in a week? Can I double dose myself? So these are very important things. I hope I have answered a little bit of that question.
Very
It's
well
not
answered.
yeah. So but keep it simple. Keep the conversation simple. Try to gain the confidence. These are game-changing drugs. And I always re-emphasize that they're pharmacovigilant. I'm happy to tell them because people say there are lawsuits, my eyes may go. I say that we are mindful of these adverse events. When you cross the road, also there's a risk of an accident and a death. But that doesn't mean that you stop crossing roads or traveling in an aeroplane or in a car. Similarly, when you take a drug, you will have adverse events. And I think we should be honest in dialogue and discussion. I think our lay people do it better and the quacks do it better. We are qualified personnel. I would love to hear how SAPI counsels his patients in Washington, D.C. And maybe Rucha Ben does it in Ahmedabad.
Thanks, Shant. That was good. Counsel patients about on obesity and MASLD is actually, as I've mentioned multiple times on my talk, is probably the most important aspect of it. But also the fact that I feel that we oftentimes don't give them enough information to make a decision on both sides, in the sense that you have F2 fibrosis. This is our current status. This is where we need to go with the medication or not. And you can either focus on lifestyle intervention and exercise or go beyond it. I think we oftentimes don't give them enough information. As a result, the whole counseling gets diluted. So I think the more information we can give to the patients, and objective information, objective findings, what is normal and what needs to be changed, probably will help both sides. And the difference of counseling between me and my fellows, I hope I give more evidence-based data. For example, as you know, the first question I get when I even try to start a statin is, am I going to get muscle pain? Am I going to get diabetes? So you need to say that, you know what, this trial was done, which showed that it's safe and it doesn't cause diabetes, and the risk of prediabetes and dyslipidemia is not to be poo-pooed at. So essentially, you need to also address those issues. The second point being, for example, I often get asked that what happens with MASLD and if it progresses and what's the next step and so on and so forth. Why should I have a combination? Is it safe at my age, right? Particularly in elderly patients. So that's when you need to look at a subclassification for statins. I often coin a study called PROSPER, which was actually done in patients more than 70 years of age. And even in those population, statins did not show any carcinoma, did not show any progression of diabetes. So those are very key points, I think, for counseling, that you need to say that, I'm quoting this particular study, which was similar to your age group with this result.
Thank you. I think those were very good insights. Let's hear from Dr. Rucha how she counsels her patients.
No, so most definitely, like Shashank just said, is patients are always asking about this thyroid cancer risk and also the eye risk, because it's all over social media. And of course, we need to, address their concerns, and also we need to give them the confidence that yes, we are going to monitor for this, and we screen if there is somebody who has had progressive diabetic retinopathy, any history of macular edema, we would not be using these molecules. So certainly, I think with a grain of salt, listen to them, give them the time. If you have at least heard their concerns, I think that's half the battle won, and they feel better about it. So yeah, Papurvi, I think thanks for bringing up a great question. I think obesity is all about behavior change, and as clinicians, we need to start first. If we don't change our behaviors, we should not expect our patients to change their behavior. So we need to make the time, change ourselves first, and listen, and then hopefully they will give us back the same respect. So I think it's a two-way street. Yes.
Thanks, Rucha. Shashank, a couple of questions. What do you think about the data on depression with semaglutide?
So I think the verdict is not out. Obesity per se is associated with a lot of mental health issues. Anxiety and depression are two of them. There is a lot of attractive basic science literature actually claiming neuroprotective effects and anti-addictive effects. So people who crave, whether they crave for alcohol or whether they crave for drugs, they actually are taken away from addiction. So I personally feel that a lot of underlying risk factors related to neurobehavioral issues like depression or suicidal risk actually stem for the fact, and that is why if you see one of my slides mentioned the filter of a psychological screening. And I think before you initiate therapy, it may not be a bad idea if there are risk factors. If you just use a simple questionnaire for suicidal risk or depression, if the person is clinically depressed, actually they can see a qualified psychiatrist. And I've also seen a lot of psychiatrists with their antipsychotic medications have insulin resistance and type 2 diabetes and obesity and weight gain. And when we start these agents, actually the insulin resistance comes down, there is weight loss, and there is actually elevation of all that. So I am not so certain that there is any cause-effect relationship on this. There is no red flag or black flag and black label on this. And I personally feel that some of this is a little unfounded. We have a very frenzy social media and a very frenzy Instagrammers who make this very viral. Just like we had the anti-vaxxers, we have the anti-GLP-1 people. I'm sure Sabi faces this in his clinic quite often. And I think we need to recognize that mental health conditions actually show an improvement. Though the evoked data in the Alzheimer's space was not that attractive, this is work in progress. And I'm very confident that this will have an anti-addiction potential. It will actually may elevate mood and may actually make, because once your self-image improves, when you lose weight, you get much more confident. And remember, on planet Earth, the two commonest diseases are what? Dental caries and depression. So, every second or third person, if you go through their filter, once in their lifetime, they will go through a phase of depression or anxiety. And it's important to recognize it. But I think if there's a suicidal ideation, which is pre-existing, then one needs to rate filter it. US is a much more litigant society. That not that the world is not a litigant society, but probably SABI faces this much more than what we do. And we had this little TJ, I know where you are coming, asking this question, Rakesh, is mainly because there was this guidance from the drug controller of Australia, TGA, which red flagged the little mental health issue. And I got a lot of calls because people went viral about it. These things reached them. I don't know what was their basis for it. I don't see any substantive literature, and both the companies were silent about it. This is just like this medullary multiple endocrine neoplasia and medullary thyroid cancer. These were all seen in rodents. I have not seen reportage of patients in this whole issue. Pancreatitis is a real risk,
Yes.
and that is a real risk. So I am very clear about it. But as far as the multiple endocrine neoplasia one, as far as the medullary thyroid cancer, as far as the mental health risk is concerned, I am not convinced about the cause and effect relationship. In fact, the reverse may be true, and we are not in prime time. And these agents may have a role. So, there is the triangle of care: heart, kidney, liver. The fourth is the brain. And I think it's very clearly there. But that data is under scrutiny. It will be totally off label, and it's work in progress. Sabi, any comments how you handle this issue of depression?
Right. So, yes, my patients come and ask me quite often, and I also work with veterans where depression and mental health is a significant issue. Uh, However, we actually went ahead and did a approximately 400 patient data. We simply gave them a questionnaire called Public Health Questionnaire. It's called PHQ-9 questionnaire, which was given to all patients. And then we stratified them based on medications that they're using for type 2 diabetes. For example, insulin, metformin, SGLT2, and GLP-1. In fact, as Shashank just mentioned, the GLP-1 group actually had the least PHQ-9 scores. So I don't see any data that supports the notion of depression any differently. We are actually almost ready to publish that data. So, as I said, there was no sign in our study that GLP-1 was doing anything worse.
So, Rakesh, I just want to add one point. Is my slide visible?
Yeah, I
Yes.
can see. We can see.
So, I often show this printout. It's in my clinic. Okay. This is the GLP-1 receptor agents and mental health, a systematic review, July, a publication in JAMA Psychiatry and meta-analysis. Okay. And I can share it with all of you. I think it's worth it. Very clearly, exactly what you asked, Rakesh. And I share it with my patient, a printout. दे देता है उसको बिकॉज वो जीव लेता है एंड वो लोग इतना इंटरनेट पढ़ते हैं आजकल तो आई एंड एक्चुअली लुक एट द कंक्लूजन ओके इट्स 80 randomized trials involving 1,77,860 patients were included in this meta-analysis. What is their conclusion? Okay, in people with overweight, obesity, and or diabetes, GLP-1 receptor treatment is not associated with increased risk of psychiatric adverse events or worsening of depressive symptoms relative to placebo, and is often associated with improvement of quality of life, restrained eating, and emotional eating behavior. These findings provide a reassurance regarding the psychiatric safety profile of GLP-1 receptor agents and suggest that GLP-1 receptor treatment contributes to both physical and emotional well-being.
Absolutely. Very
I
good.
personally feel showing this may be useful. I hope I would be happy to share this. I share this with people because I think, people really have, the type of people we see, me, Purvi, or Bansi, or Ucha, or Rakesh, you see, or Sabi, we see, they actually ask this. And therefore, I want to show them that there is a systematic review addressing this question, scientifically addressed with more than 80 trials, which are well designed, exactly addressing this issue.
Yes,
And there is nothing much in that. So, I just don't know from where these Australians came out with this wild idea. But Australia as a country is a little more wilder and a little more crazier. And they have a higher incidence of suicides rest of the world. Remember, they were outcasts from United Kingdom. So they have definitely a a relatively abnormal mental health gene with them. They are aggressive people in general. And I don't want to say much more on that. The less said, the better, because we should not be inappropriate in our comments. But I think, therefore, there may be a little higher risk in those people in general also. So I don't know that, but that's the truth. If you look at the literature, I'm only talking of science and literature. That is the truth. But maybe Rucha and Bansi can
This is
give.
exactly where precision medicine will come into play. So if we could understand, the genetic makeup of the individual, the underlying mental health that would predispose, we would maybe not select certain molecules for them. So I think my topic was precision medicine, precision nutrition for obesity. I think that's a great point you make. Just like in Europe, they have the FTO gene, so they're already predisposed to obesity. It's very prevalent. So when we are studying this precision medicine, or omics as we call it, that's where this might come into play. So I think, Shashank, that's actually a very valid point that you made, that if we knew about it, just like medullary thyroid cancer, it's a genetic predisposition, you're not going to have it. And there is going to be a good meta-analysis coming out from Canada where they have looked at protection for other types of more common papillary thyroid cancer and so on. So I think there's a lot to
ACE
be
came out
said.
with the MEN1 guideline. I don't know many people know that, but ACE actually came out with the MEN guideline. And it's uploaded on website again fully. Rakesh, me, Bansi,
Yeah.
all of us very closely work with ACE. So is Purvi, Racha, and Sabi. But very clearly they came out with an MEN. I agree with you. Precision medicine is there, but this mental health issues, Rakesh, I hope I put
Absolutely.
it to rest.
Yeah,
But
yeah.
as I said, when you
Conditions
show
that
them a
we
document
deal
on their face, but even after that, somebody may still commit a suicide. It doesn't mean that a patient may not commit a suicide.
But
He may
I
still
think the
commit a suicide.
baseline risk itself is so high. The conditions that we're dealing
It's
with
all on
are
the
so
denominator, but even after the denominator was studied in a scientific way under scrutiny in a randomized environment, the data is very clear.
great. So I think that's been a slightly different discussion than our usual one, but really very valuable. We still have a couple of minutes, and I think all of you have expressed that you'll want to maybe one last question
Bansi,
for Dr.
Bansi has been very quiet
Quiet.
today. Bansi bhai,
Was listening you, sir.
kem cho?
So wonderful. Thank you, Shashank. Thank you, Sebi, Rucha, and Purvi, and particularly Dr. Rakesh, who is moderating our session, who is currently organizing secretary for Diabetes India 2026, which we are going to have at Hyderabad under his leadership at HICC, Hyderabad International Convention Center. I'm thanking Obesity Society, particularly Dr. Sen, for giving us this opportunity. He is a executive board member of Obesity Society, for this collaboration that we could do a co-branded webinar, and where more than 680 doctors who have joined. We were having around 800 doctors who registered for the meeting, but there are a few more webinars where we will be there in next few weeks. One we are doing with American Diabetic Association, we are doing with Carbilo. So we are doing few more webinars with few more organizations. So I'm sure please see our website, see our social media messages from Diabetes India, and log in for the meetings. With this, I thank once again to all the speakers, and good night. I think Sebi told me that 10 o'clock he has to leave, so this is the right time we can close the session. Thank you.
Thank you, everyone. Goodbye.
Thank you, sir, for
I
the
would
Thank you
wish
so much.
everybody
Thank you,
a
Lan.
very happy Christmas and a very
Merry
happy
Christmas,
2026.
Sandy.
I
Merry
take this
Christmas to
opportunity to
everyone.
wish everyone.
Yes.
compliments
Thank you
of
so
the
much. Wish
season.
you all.
Bye.
Thank you. Bye bye.